So I'm going to be reviewing what are the dominant school mental health interventions. Largely, the most common one, which is school-based counseling, of which we know very little. Thanks very much. That'll work. And then two more recent trends: social-emotional learning programs and positive behavior intervention supports. And what I'm going to be doing is framing this for you from the perspective of children's mental health, what the issues are with children's mental health. After all, this is school-based mental health, and how these interventions so far are holding up. And what I'm going to be doing a little bit is talking about the limitations that I see in these approaches and some recommendations for where I think we need to go. So, as was already mentioned this morning, children's mental health has really become a national priority, and that started with the very first Surgeon General's report on children's mental health, which identified this as a priority. And it's hard to believe, but that was only about 10 or 12 years ago, 14. And then followed that, there was another presidential commission called the New Freedom Commission, which reviewed the literature, determined that mental health services for kids are fragmented, disconnected, inadequate. So we've known, and this has been around for a while now. These were summarizing some literatures, some of them related to Len Bickman's work that was mentioned earlier. When we take a look at kids' mental health services, one of the things that we see is that this is a study, this is an epidemiological study done out of North Carolina, the Great Smoky Mountains study, and they tracked kids' mental health services for to determine where they were receiving services, and they did it as a function of what kind of need they had. So you see on the bottom there, these were independent assessments done of the level of need. So in the first group, there was actually no identified need. And then in the middle group, there was mild, and in the third group, there was high need. And when you take a look at where the services were offered, the things that become most clear is how prevalent schools were. And this was an independent study done across the Appalachian region. Even in the high need group, schools were still the primary source of services for kids. And there's actually evidence to suggest that when kids receive services in school, they're actually less likely to receive them in clinics. It's almost as if they're separate systems. Note the very small percentage of services that are received in mental health clinics. Hospitals are up there as well. When we take a look at the types of services that schools are providing, we see that there's a wide range of services. Some of these relate to learning disabilities. So what we mean by mental health services is very broad. Schools are very active. They're not particularly designed to do this, but they're having to do it because they can't turn kids away. And you can see that the need that they identified is the types of problems that they're seeing are the kinds of problems that we would expect to be seeing in mental health. So what we see is that these are more descriptive data about what's going on. What we know very little about is how effective these are. And I'll just give you just a little hint as there is very little literature telling us whether this stuff's working or not. We have reason to believe it's not. And I just offer this as one example of what I think suggests that schools are being burdened with something that they really can't manage very well. And this is just looking at high school graduation rates. This is looking at longitudinally from 1987 to 2006. And I don't think this has, So if you take a look at the top lines, what we see is kids who have speech problems, kids who have learning disability, kids with mental retardation are graduating at rates of 70% and above. Kids with behavior disorders are actually stagnating and barely at 50%. So these are the kinds of emotional problems that schools are not managing very well. The mental health system doesn't seem to be participating to the extent that it needs to, mostly often due to stigma, often due to lack of available services. The prevalent models for school mental health, probably there's about three that seem to me to be the most prevalent. The one is what I call the clinic within school, and that's the what you could call a medical model. This is sort of assuming that we can place a clinic like a health clinic in a school. In this case, it could be a mental health clinic, or it could be a counselor in a health clinic, and that they will provide services in that clinic the way they might outside of a school. We did some consulting with New York City schools a number of years back, and 50% of the kids who were receiving special ed services received counseling. Often we were tracking these counselors, and often they spent more time walking in the halls picking these kids up than they did providing the counseling. Literally, it would take them 10 to 15 minutes to get the kids, 10 to 15 minutes to meet with them, 10 to 15 minutes to get them back to their class. Not an effective model. And in general, counseling is not especially effective for a large number of problems that kids are experiencing, such as ADHD or conduct problems, disruptive behavior. But the bigger issue is the capacity to deal with the large number of problems, and that's where we get a little bit concerned about these clinics within schools not being able to manage the large capacity for needs. The other model that's very prevalent in school actually comes from school, and you might call it the special ed model. And this is where they target the high-need kids, and they have a special program just for the high-need kids. These models are actually often popular within the schools because you take the most disruptive kids in the school and you put them off somewhere and you have a special program for them. The rest of the school is actually feeling comforted by that at times. It's not especially effective. It hasn't been evaluated very well. And it's not going to deal with the vast number of problems that are going on in schools. And then the last one, which is one I'll be spending a little more time talking about, is what you might call the school reform model, which is sort of a whole school approach. In some respects, charter schools reflect this. When charter schools are set up to deal with special needs and so on, they would reflect a whole school approach. These are not typically replicated. They're difficult to sustain. So what we see is that these models that are going on in school mental health now are not necessarily addressing the extensive problem that we see, and they're certainly not helping schools deal with the burden of having to deal with mental health problems because of these capacity issues. So let me just say something about the evidence for school counseling, which is very little. School counseling is, from the surveys that SAMHSA has done, we know is the prevalent model for school mental health, but there's almost no literature on it, and the literature that is available is inconsistent. So for instance, a evaluation of a school counseling program out of Vanderbilt compared it to tutoring and found that there was actually no benefits on any of the mental health outcomes over and above those seen for kids getting tutored at 2-year follow-up. There was a meta-analysis that did find effects, but it found it only for group administered and only on youth self-report, which is probably an extremely unreliable measure. So my conclusion is not that counseling doesn't work, it's that we don't know. I have a problem with counseling as a primary way of intervening because we don't have the capacity to manage the need. But we just simply don't know the extent to which counseling is helping or not. Despite that, it's being used most commonly because that's what people are most comfortable with, I would suspect. More recently, prevention has become much more popular and well disseminated, and there's a program based out of my university called CASTLE, which stands for the Collaborative for Social Emotional Learning. This is taking an approach that kids' mental health or social abilities can be thought of the way schools think of academic programs. So basically what they've done in CASTLE is they've identified a series of programs that focus on improving kids' ability to get along with each other and to take care of themselves and so on. And I want to sort of comment that I think it's a very important, the timing of it is very important at a time that we had the No Child Left Behind Act, and that we often call the No Child Left Untested Act, because that seemed to be primarily what it was doing. So I think the social emotional learning movement, I think, has done a very important thing by bringing attention to the fact that schools are involved in much more than simply teaching reading and writing and math. And in fact, there's a good literature to suggest that this is well aligned with educators' concerns about kids. They are typically concerned with kids' emotional development. The CASEL has defined social emotional learning. Note that they suggest that it's as appropriate for adults as it is for kids, though that isn't often implemented. We'll talk about that in a bit. And it's defined these set of criteria and so on. And I suspect that many people in the audience here are familiar with many of these programs. And then, with a great deal of fanfare, they've done a meta-analysis, put it on websites. It's now being promoted across the country, that took a look at what have we learned over the last decade or so about these social emotional learning programs. Just a little bit on a meta-analysis. For those not familiar with that, this is a way of summarizing a number of different studies, pooling the data to see if we have some overall trends. So it's an opportunity to increase your sample and to actually see if the literature is conforming in a way that makes sense. And I will again share this information on effect sizes, as you heard earlier. So I picked 0.30 as a small effect size. Anywhere between 3.0 and 6.0 is moderate, and above 6 is strong. The difference there with earlier is not important, I don't think. And what CASEL did was they took a look, first of all, at universal programs. These are programs that are school-wide, done with all kids, not kids just with problems, but presented to all kids. 180 school-based studies, almost 300,000 students. They also took a look at what they call indicated. These are kids for whom there are special needs, at risk but not in special education. 80 studies, 11,000 students. So you can see the advantage of a meta-analysis is we have a lot of studies and a lot of kids that participated in this, and we can get a sense about whether there are trends. So this was what they found on the universal results. First of all, let me just say something about the column all the way on your left, which is the skills. That's a manipulation check. That's a measure that the kids actually learned what they were taught. The rest of them are generalizable. Generalizable skills, attitudes, social behavior. I can't even see the rest of them. But so what you can see is the effect sizes are all small, with the exception of some academic skills at follow-up, which are approaching 0.3, which is still considered small. And then we take a look at this as a function of who delivered the service. Can it be delivered by teachers and all that? Again, we see largely small effect sizes, except for the manipulation check. But then when you take a look at the indicated studies, now the effect sizes are starting to approach moderate, and that's very encouraging. So what we're seeing here is, even on follow-up, that some of these things can maintain over time as an indicated intervention, meaning it's for kids who are at risk, who are showing early signs of problems. So conclusions, you might say, is SEL programs produce positive results for most children and best results for children at risk for behavioral emotional problems. However, program content implementation quality is highly varied with small effect size for most outcomes. And most importantly, I think from the perspective of schools, these meta-analyses and this literature does not tell schools which programs work best under which conditions, which I'm going to continue on. But that's their meta-analysis. Now, there was another study done, and this was sponsored by the Institute for Education Sciences. They took 7 leading research teams and selected them from a pool of 90. And these were all very well-known identified social-emotional learning programs with random assignment, 3-year evaluation. You can see that quite a large sample size. And then what they did was they then did an independent assessment, not the research team's own assessment, but an independent assessment of whether this was working or not. And then this was an acknowledgement of the importance of social-emotional learning and also an opportunity to see whether we can independently determine its effectiveness. They measured 20 outcomes in 4 domains. It was all self-report, which is a limitation of this. And the results were 2 positive program effects from 60 tested, 9 positive effects, 7 negative effects of 420 tested. And it was not due to, they took a look at a bunch of stuff, subgroup differences, gender, socio-economic status, differential program impacts, did not. The programs were impacted with high fidelity as determined independently. And so the conclusions. No improvement on student outcomes when considered together, individually by program or specific subgroups. Combined individual program analysis found fewer significant impacts than expected by chance. And then the quote, in sum, the SACD combined program evaluation provides no evidence that the 7 universal school-wide programs improve students' social and character development. So now we're starting to get a little bit concerned, but let me just take another. And this is just one example. This was the second step, which is a very prominent social-emotional learning program. This was an independent assessment by the Gottfredsons, and they indicated the results provide little support for the use of this particular instructional program to prevent problem behavior or promote social competency. So despite what the Castle program is suggesting are some positive, encouraging trends for social-emotional learning, when you break the literature down a little farther, what you see is it may be specific to indicated, but in this particular study, they were not even able to find that. So what went wrong? Well, maybe the schools didn't implement it correctly, but they actually did do fidelity assessments. Maybe the schools are already using these social-emotional learning programs, but they found that the intervention schools reported higher use. And then maybe these programs make the most sense for those students who need them most. Maybe what our problem is we're trying to do one-size-fits-all, and that's not going to work. So let me give you one more example, and that's the Fast Track program, which might be the best funded study other than the MTA of children's mental health. 7,600 students, 55 schools. This was a multi-component study, but the thing I want to point out is that they all use this one curriculum called the PATH curriculum, and promoting alternative thinking skills is what it stands for. It's very, very well studied, very well-known program. The at-risk kids got extra services, tutoring and social skills. They did random assignment, 3-year evaluation. And they looked at it across a bunch of domains. About 40% of the interventions were significant. And that was in year 1. In year 3, about the same, about 37%. Now let's take a look at the effect sizes again, because that gives us a little bit of a sense of how powerful these effects are. And again, what we're seeing is they're generally very small effects. I do want to point out small effects don't mean bad effects. They just mean small effects. They mean that you're not going to get a lot of power for the intervention. It doesn't mean nothing happened. But you do want to be cautious then when you're promoting something that's having a small effect as if it's going to solve a big problem. And that's the point that I want to raise with you. So now people are starting to think a little differently about these social-emotional learning programs. They're not looking at them as a one-size-fits-all that everybody needs to implement it. they're talking about integrating these social emotional learning programs into routines and daily interactions, what I would call more of an ecological view. Also becoming much more aware of what is it going to take for schools to use this. As Bill mentioned, I've been working in inner city schools in Chicago who don't have a lot of resources and don't have a lot of time. So when we're suggesting programs for them, we're trying to think about the ones that are going to make the most sense for them with the least amount of resources. It's a nice report, social policy report by Stephanie Jones and colleague that just came out that describes this integrated approach nicely. And this is from a study that she published in Journal of Consulting Clinical Psychology, combining and integrating the social emotional learning program with a literacy program. So I think where I think the field is starting to go with this is I think it's starting to see that we need to be combining interventions in a much more sensible way that's going to make sense for the schools. Not just promoting programs that we developed that we want to see go forward because we think that our program is better than someone else's program. From the perspective of a school, what we want to think about is what's going to make the most sense for that school given their population and given their needs. So another critique of SEL effects is, are we changing settings or are we changing individuals? Are we understanding that behavior is occurring in context? One of the things that you could, one of the ways you could criticize the literature is you can be concerned that there have been what you might call settings of convenience, which is how did we get into that school? How did I do that study at that school? Is it replicable across other schools, or was it a school that I knew well, that I've been working with a long time? And I think the IES study that did this independently and found very few effects would suggest that there might be some of those concerns about selection bias in terms of what schools are getting in there. And essentially what we go back to again, and this was something that I learned early in my training from Bill and others, which is what we want to be thinking about is what works best for whom under which set of conditions. And so what I want to suggest to you is another way of thinking about the school mental health programs. I want to suggest to you that we think about it from an ecological perspective, and ecology is the study of reciprocal relations among natural elements in an environment. I want you to think about a school as an ecology, reciprocal relations among natural elements in an environment. These are some of the definitions of sustain: able to be maintained at a certain rate or level. That's the one we're most familiar with. Conserving an ecological balance by avoiding depletion of natural resources. Are we concerned about that in schools? Are we concerned about going into schools as mental health people and using resources or using time in a way that they don't have? If we're doing A, B isn't going to occur. So what we need to be thinking about is what are the most important activities in schools and how do we maintain this ecological balance? The other definition of sustain comes from law, and it's able to uphold or defend. And I bring that up because I often wonder whether the principals that we're working with understand what we're doing. Could they tell their teachers, could they tell their parents what the goals of these programs are in a way that makes sense to us? And I think sometimes we bypass that. They have other things on their plate, and we bypass that. So the way that we've been understanding ecological interventions in our work is a way to understand that behavior is occurring in context, all behavior, all of kids' behavior, whether it's socially, emotionally related or behavior problems or academic. And so what we want to be able to do then is we want to take the local resources that we have available to us, and we want to make sure that whatever we're trying to do is driven by those local norms, which implies that we're going to be working in collaboration with the people in our setting. We're not going to be imposing something on them. And therefore, sustainability will be maintained if it makes sense to the people in the environment. I bring that up because of the concern sometimes about interventions not being used by teachers, and then our attitude might be that the teacher is being inappropriate, or the teacher isn't being professional because she's not using a favored program of ours, such as a behavior management program. But we turn that around in Chicago and we say, well, what that means to us is that this program isn't making sense to this teacher. Now, it may be because she doesn't want to leave her desk, or it may be because she doesn't like the way the program goes. But our effort then is to understand, how do we change her behavior? How do we help? How do we manage to change the environment in such a way that it's going to make sense for her to use programs that will make her classroom work better? And from a public health perspective, mental health usually is up here in the intensive. We get kids referred to us and so on. That's where mental health services go. And the at-risk programs are targeted, and what we do very little of are these universal interventions. It's very hard for us in mental health to do that, but this is what we're trying to do. If we can build this base of strong universal programs in schools, then the targeted and intensive interventions will work that much better. Very encouraging in the US here, as many of you know who are in schools, we have response to intervention, which is a change in the special ed laws. It allows districts to determine special education need based on non-response to intervention. So schools have to document that they've tried these things. So now schools nationwide are setting up these 3-tier models to try to promote effective services. This is a terrific opportunity. The school psychologists no longer have to only do testing. They're now freed up to help consult and work with teachers and other staff. So I think it's a terrific opportunity, and it's a time when important changes could happen. At the same time, within the last decade or so, there's been another current that's been sweeping schools, which is called Positive Behavior Intervention Supports, or PBIS. This was based out of University of Oregon in the 1980s. They basically started with the idea that they wanted to disseminate effective behavioral interventions for students with behavior disorders, simple as that. Photo there of Rob Horner and George Shagai, who were the developers of this. And then a national center got established. It actually got written into federal law, this national center. As of 2010, over 9,000 schools are implementing this program nationwide. Now, PBIS is not a program in the form of a package. It's a set of principles. But I think it's worth bringing up this guy on your right there. I hope everybody knows who that is. Sigmund Freud. No, it's not Sigmund Freud. You all knew that, right? It's B.F. Skinner. And we actually know a great deal about how to decrease disruptive classroom behavior. We've been used to looking at effect sizes of 0.2 and 0.3 and 0.4, and we're really excited about 0.5 and 6. Oh, sorry. 223 studies of classroom behavior management programs had pooled effect size of 0.78. It's approaching 0.8. We know a lot about this, right? We don't have to bypass this. A lot of this is based on Skinner's work. I will point out the observations had stronger effect sizes. One of the problems in the school mental health literature may be that we're not doing rigorous enough research. So we're not getting the observational data to help us know if things are really changing. That's a possibility too. Good Behavior Game is a classroom management program developed in the late 60s that has been studied widely. And this I added this slide, so it's not in your handout. Sorry about that. Got busy last night. So what this shows is the random assignment to Good Behavior Game or not, which again is if you're not familiar with it, it's a classroom management strategy. It's very easy to implement and all that. And it shows a pretty strong effect in terms of a reduction. This was actually looking at attention deficit problems in kids. And my point is that these are programs that are out there that have been around a long time that we know a lot about. Why are we fooling around with programs that have effect sizes of 0.2 and 0.3 when we have programs with effect sizes of 0.7 and 0.8? So now I want to go back to PBIS for a second. I just wanted to make the case that it's based on a pretty strong foundation. Again, it's a framework, not a program. It's using this three-tier model, which is basically saying that we need universal programs to address the school-wide problems and then figure out where the need is from there. Target, they don't only target kids. In fact, they very rarely target kids. They target settings. So for instance, if one of your concerns is bullying in the school, then we already know some of the settings where bullying occurs. We might target the hallway. In fact, the PBIS people might target the third grade hallway because that's where they're showing that the bullying is occurring the most. So they're using data to help drive the services. Fits very nicely with the changes in the special ed laws. Response to intervention and PBIS fit very nicely together. These are some outcome data on 21 PBIS and 16 comparison schools, indicating some nice changes over time. And there, the effects on math and reading are not as pronounced. They're much better at impacting on behaviors. Here's some data on bullying, which indicates that PBIS across 12,000 kids has a positive effect on reducing bullying. It didn't eliminate bullying, but it's reducing bullying. So I think these are very encouraging trends, and they're more school-wide trends. They're thinking about schools as holistic settings. From an ecological perspective, that's the way we would want to think about it. They're not concerned about whether a program is implemented. They're thinking about how do we organize the schools. And I think it's a framework. What I'm encouraging you to think about with this literature, if you get into the literature, is I'm encouraging you to think less about that we know what works and more about how we think about how to intervene in schools, how we think about helping schools be stronger settings. And my colleagues in Chicago, and most notably my colleague Stacy Frazier, who's in the audience over here, is at FIU now, and I have been thinking about what are the implications of taking a public health approach to approaching kids' mental health needs, and what we call is taking settings seriously. So what we want to first do is we want to consider that we have to have an expanded workforce. We do not have enough counselors, social workers, psychologists, people like that. We want to go from a limited number of trained professionals to really understand who are the key people that impact on kids' lives. It's not going to be, hint would be it's not going to be a school psychologist, most likely, much more likely to be a parent and teacher. How do we realign the mental health resources then to impact the key predictors that are known to help kids succeed in these settings? And the setting I'm talking about now is schools, but Stacy's work has been in after school using the same set of principles to advance kids' development and adaptation in an after school setting. And most importantly, for us, what we think is really important to understand is that it's really the setting that's going to be setting this up, meaning the people within the setting, and they need to set this up at a pace that makes sense to them. And that may not be within 1 year. It may not be within 1 semester. It may be across years. And that suggests that we have relationships with these schools that allow us to work with them over time and encourage them to consider what are the intervention programs that are going to make the most sense for them. What it does then is it provides the mental health field something that we've been lacking, which is a natural progression from prevention to intervention. If schools are a setting that kids spend a great deal of their day, and we know they are, and if schools become a safer and more healthy place for kids to learn and interact, then we now have solved a large mental health issue, and now we can adapt programs to deal with other issues that come up because schools are going to need some help with other issues that come up as a result. And that's the notion of a public health approach where you have a universal, targeted, and intensive intervention. Just as an example of Stacy and I wrote a paper which I cite down there. And my working title of the paper that Stacy would not let me use was if the mental health community were in charge during the H1N1 crisis, we'd all be dead by now. And the reason I wanted that as a title, and we actually started the paper with a quick summary of that, is you all remember, I think, don't you all remember that H1N1 crisis a few years ago? And you remember that it sort of swept the country. In fact, it swept the world. And within a couple of months, there was an outbreak, an incidence of H1N1 virus in every single state in the United States, internationally as well, right? And they had a vaccine they were developing. And do you remember, does anybody remember what happened right after this vaccine got developed? Well, let me just give you a clue. What happened is, this is the United States of America, right? So this is where, if you have money, you line up and you get that vaccine. In fact, you'll buy 3. What the heck? You might need it down the road, right? Except in this case, the World Health Organization and the Center for Disease Control said, no, not this time. This is too important. And they would not let people buy that vaccine. Do you recall this? Do you recall who they said that vaccine had to go to? That's correct. Exactly. They identified an at-risk population. They said the elderly, they said pregnant women, they said people with immune deficiencies, right? These are the people who are going to get this vaccine because we only have a limited supply of that, right? That's what they did. Now, do you remember what else they did? They did isolate the infected, and they did one more thing. They put us all back in 3rd grade, and they taught us how to do what? They taught us how to sneeze into our elbows. They told us to wash our hands. And I have to tell you, there's been some follow-up, and there's some suggestion that that didn't work, but that's not what it was there for. It was intended to reduce the spread of infection. Whether it did or not, it gave us all something to do to make us feel better, right? So that was part of that public health campaign. It was inexpensive, didn't cost very much to get us to wash hands and sneeze into our elbows, and they controlled the vaccine. And now, think about if the mental health community were in charge. How do mental health services get allocated, right? The people with the most need get them? No, we already saw that. The Great Smoky Mountain study showed us that that wasn't the case. People with the highest need are not most likely to get mental health services, right, because of lack of access and other things, right? And then we also don't have a strong public health campaign to promote children's mental health. For instance, why is it that we spend more time teaching people to drive a car than to parent? How come? I mean, if we did that single thing of having it that everybody who was going to be a parent got some classes, I suspect we would improve things. Maybe that's happening. I don't know. I'm not familiar with it if it is, but I would be encouraged. So to continue on about this, so then what we start thinking about from this public health perspective is school goals are mental health goals, right? They're not, I'm not even talking about a synergy. I'm not even talking about adding school stuff to mental. I'm talking about the fact that kids doing well in school is in and of itself an extremely important mental health outcome. And the literature is quite clear on that. I really point to this study that was out of Emory University that tracked over 1,000 kids from kindergarten through high school and found that low grades and aggression in 1st grade predicted not graduating high school with an effect size of 0.78. Now we already know that's a pretty decent effect size for our field, but importantly, this is going from 1st grade, I think it was 1st grade, not kindergarten, 1st grade predicting high school, 0.78. That's scary. So that means we got to get busy. We got to get in there, and we got to be very aggressive in working with kids in schools and helping them succeed. At the same time, there's a national spotlight on schools. As I mentioned, No Child Left Untested. It's been around a while. U.S. ranking of 30 countries. We're 25th in math. We're 21st in science. There's all sorts of concerns about teacher competency and school violence. I have that picture up there. Anybody know what that is? Anybody know what that's a picture of? It is Sputnik, right? I did this with an undergraduate class. I asked them what Sputnik was. You don't want to know. It's something to do with Star Wars, but anyway. So there are a few of us who remember this, but the analogy here, the comparison to Sputnik is what happened I'd have a discussion with you, but we don't have time. So what happened is that the the Soviets got a satellite up before we did. And that scared everybody because they're going to go on the moon and they're going to shoot us from the moon, right? So all of a sudden, math and science was encouraged. Big increase in math and science funding. Well, that could be going on right now if we had a government that knew how to allocate funds. But we're 25th in math, we're 21st in science, we're falling behind in the race. This is the emphasis that's going on in schools. They're not worried about our social emotional learning program, are they? They're worried about becoming an effective school. And we want to make the case that being an effective school is an enormously important mental health outcome. This is a nice model that we use to identify what it is we mean by effective schools. Boyd and Schaus proposed this, communality and academic press, and you can see that if you're in the quadrant that has low academic press, no one succeeds here no matter how hard they try. We see that too frequently in the inner city. Or high communality, which is everyone succeeds here whether they try or not. That's not going to work either. And then there's high academic press without communality. Not everyone succeeds even if they try. And what we're shooting for is that sweet spot where both are going on, where effort matters. If you make an effort, you're going to succeed at this school. That's what we're shooting for. That's a mental health enhancing setting. Teacher stress, this is a quote from the New York Times, low morale, depressed. I can't even, feeling unfairly blamed for the ills of society, you must be a teacher. And notice that was in, what was it, 97? 50% of teachers in high poverty schools leave within 3 to 5 years. That's incredibly destabilizing of the schools. This is a work of our colleague Elisa Chernoff. Teacher shortages due to migration and attrition. Up to 20% of public school teachers leave within their first 5 years. New teachers often placed in the hardest to staff schools. And then I've been talking to people about this school mental health notion, and often what mental health folks say to me is, look, it's just not our area. You know, we're not educators. Well, this came out of the national academies and, you know, a decade ago. And notice the two things I highlight there. This is what they suggest is going to make effective high schools. And the two things, they're talking to schools now. Foster personalized learning environments that enhance student-teacher relations and diffuse school guidance and counseling services among staff, including teachers, with support of mental health professionals. Well, I'm glad I showed you what Stacy and I wrote first, because you would have thought we stole that from them. But I was very glad to see that because that is obviously something that we're going to need to do as a mental health field. We're going to need to figure out how to give stuff away. And fostering personalized learning environments to enhance student-teacher relations seems to me eminently doable for a mental health person. This is right in our comfort area, I would hope. So what we're trying to do then is we're trying to refocus programs to enhance teacher-student and parent-teacher relations. And we're doing this with community mental health providers to promote positive school adjustment by looking at the key predictors of academic, social, and behavioral success, and to enhance the diffusion of effective practices through the unique networks of teachers, parents, and students to reduce the silos of mental health. I'm going to talk a little bit about the social diffusion theory that we use, but this is a way of understanding how ideas spread through a social system. These are our colleagues, Elise Capella and Bridget Humry. Elise is at NYU, Bridget at University of Virginia, and they developed a project that was published in Journal of Consulting and Clinical Psychology that they called Project Bridge, where they took some of the behavior management work that we'd been doing in Chicago. Elise worked with us in Chicago before going to NYU. Bridget's been doing a lot of work with Bob Pianta at University of Virginia, working with teachers directly, teaching teachers how to be more engaging with their students and all that. And they bridged these two. They brought them together. They taught mental health professionals the same set of techniques that Bridget was using with teachers. So the idea was now the mental health professionals were now counseling teachers on how to be effective teachers, as well as incorporating some of the behavior management principles. And they had nice effects, especially in classrooms with low support. These were the classrooms where they really needed the most help. And I'm just going to wrap up. This is Ev Rogers, who is the guy that's most known to be to have promulgated the concept of diffusion of innovation. Innovative interventions initiated by a relatively small segment of opinion leaders, and then they're diffused through the population. I always like this quote that he noted that despite their knowledge, professional change agents often have little or no influence. Any psychologist like me that works in schools knows that really well. And what it means is you partner with the people who are important in those social settings. These are some of the indigenous resources. Bridget Leachman is one of our lead parents, has been one of our lead parents, and those are our peers and other adults. And this is just some of the way that parents can be supporting other parents to work in schools. This is from a study we did a number of years ago, published in the leading mental health services journal in the country. And it just shows parents' use of services, and using this very flexible approach, we were able to get parents using mental health services and attending workshops and things like that at a very high rate because we were extremely flexible. We had people coming in their homes, we had sponsoring activities at school, and Mary McKay was very involved in this work, and it's where she and I did a lot of our work together. You can also see that in this particular study, this was out of that same study, we had a much higher rate of kids' use of services because we were in the schools. Parents had to sign up at 1 year and agree to keep their kids in, and they did at a pretty good rate. And then we've just replicated that finding again in another study that we did using a variation on this model that we call links to learning, where again we're showing relative to control group we can get services to kids. I'm just trying to make the case that these service models, these ecological perspectives, make sense from the perspective of schools, we hope, but also make sense from the perspective of kids and families. And these were some classroom observations where our links kids across 1 year were able to show that they improved on their academic performance relative to the control group. Okay, so I'm going to wrap up. School-based mental health services are the leading service setting for children and youth. Social-emotional learning and PBIS indicate strong support for mental health goals. That is, that their adoption indicate that, although the results are highly variable and I would suggest somewhat modest. Ecological models can enhance effects and improve outcomes by focusing on schooling as a key mental health goal. And I'll end this with what I consider my attempt at a haiku: by attending to the unique characteristics that inform and promote school success and the activation of indigenous resources to support and sustain school goals, not to make school mental health services the job of schools, but to make successful schooling the job of mental health services. Thanks.